Hey everyone, welcome to today's Explainer. We are tackling what honestly might be one of the most intimidating challenges in all of medical education, and that's clinical imaging of the skeleton. Look, if you've ever stared at an X-ray and just felt this massive wave of panic trying to recall a seemingly endless list of differential diagnoses, trust me, you are in the exact right place. Our main goal today is to take that overwhelming rote memorization and transform it into a logical, pattern recognition framework. We're going to look at the skull, the spine, and the extremities, and we are going to completely change how you see them.
So, you might be wondering, how on earth do you memorize 30 different diseases for a single bone? Well, spoiler alert, you don't. Honestly, there's no way. The real secret of master radiologists is that they aren't just pulling from some giant mental list. They read the pattern, not just the film. They ask really specific sequential questions about what they're actually looking at, and then the anatomy basically does the sorting for them. And by the end of this explainer, you're going to have that exact same cognitive framework.
All right, here's our roadmap for today. We're going to start with reading the pattern, do a quick skull home inspection, stack some spine blocks, hit the extremity construction site, and finally we'll weigh benign versus aggressive pathology. Okay, let's dive right into Section 1, reading the pattern, architectures of the body. And moving right along to Section 2, the skull, and our home inspection analogy.
To really get away from rote memorization, we have to anchor all this abstract medical data to something concrete. So we're going to use physical, architectural analogies. Because once you see the architecture, the diseases simply become structural failures that make logical sense. Take the skull, for example. The skull presents 11 complex pathological patterns. Trying to memorize those in isolation? Absolute nightmare. But if we set up a spatial metaphor and inspect it exactly like you would a house, those 11 conditions get instantly organized. First up, check the foundation and frame. Has the base migrated upward, or did the sutures close on schedule? Next, you check the walls. Is there generalized density change? Like, are the walls too thin and washed out from demineralization, or are they way too thick? Then look for holes in the wall. Are there focal lytic lesions punched clean through? And finally ask, what's in the rooms? Have the contents of the pituitary, fossa, the brain, or the sinuses changed, swelled, or calcified? By simply asking these 4 basic architectural questions, you're literally doing most of the differential diagnostic work for yourself before you even name a single disease.
Now, when we're out there checking that foundation, a hard measurement threshold beats a gestalt, a gut feeling impression every single time. 8 millimeters and 10 millimeters. These are the absolute upper limits for McGregor's line, which is measured right from the hard palate to the inferior skull margin. If the odontocoid tip sits more than 8 millimeters above that line in men or 10 millimeters in women, boom, you are dealing with basilar invagination. That's where the spine is actually pushing upward into the skull base. Seriously, don't guess, measure. So the absolutely crucial point here is knowing what to do when you actually find a structural failure. That's where our high-stakes skull decoders come into play. If the foundation fails and you've got basilar invagination, I want you to think COOP. That's congenital osteogenesis imperfecta, osteomalacia, and Paget disease. Now, if you find a hole in the wall, a solitary osteolytic defect, use Help Me. Hemangioma, epidermal, leptomeningeal cyst, Paget, post-surgical, metastasis, and eosinophilic granuloma. And look, I don't want you to frame these as just extra memorization. Treat them as emergency retrieval tools to decode the image when you're under clinical pressure.
All right, heading down to Section 3, the spine, or, as we're going to call it, stacking blocks.
So, moving down the anatomy to the spine, we're leaving the house inspection behind and bringing in a brilliant new analogy. I want you to visualize the vertebrae as a stack of blocks connected by springs. Just like the skull, the spine has over 30 diseases and 13 distinct patterns. But by simply asking 4 questions about our blocks, we effortlessly sort them all out. Question 1, is the block shape right? Is it wedged, biconcave, or kind of squared off? 2, is the stack aligned or has a block slipped, like what you'd see in subluxation or scoliosis? 3, has the space around it changed? Are the discs narrowed or is there a weird soft tissue mass? And 4, is the bone itself intact or is it eaten away, too dense, or just entirely collapsed? Answer those 4 and you've basically conquered the spine.
Now, when you're looking at the space around the blocks, specifically the discs, you really need rapid triage tools. And this brings us to the vacuum phenomenon. This is literally gas appearing within the disc space. Why does this matter? Well, because it strongly favors a diagnosis of simple degeneration, where joint wear is just releasing nitrogen gas. If you see a narrow disc space and you're suddenly worried about a really dangerous infection, look for the gas. Infection classically does not produce a vacuum sign. It's this incredibly high-yield gestalt sign that immediately points your clinical path in the right direction.
But what if the bone itself is actually being eaten away? If you've got an osteolytic spine lesion, location is absolutely everything. These two mnemonics, call home and go ape, they aren't just random lists. They brilliantly illustrate the exact same osteolytic differential, but split entirely by where the lesion sits in the vertebral block. So call home covers lesions right in the main vertebral body, like chordoma or multiple myeloma, while go ape covers lesions sitting back in the neural arch, things like giant cell tumor or osteoblastoma. Literally, just by identifying the zip code of the lesion on the block, you've cut your differential right in half.
Moving right along to Section 4, Extremities, the construction site. For the long bones of the arms and legs, the vibe shifts again. I want you to visualize every single long bone as an active construction site with a growing end. On this site, every long bone tells the exact same 4 stories. Walk through this 4-step read with me. Step 1. A hole opens up. Is it a slow dig or a super destructive break-in? Step 2. Too much material goes in, and that creates dense, sclerotic bone. Step 3. The crew reacts. When you see periosteal new bone or joint reactions, remember, that is the body's construction crew reacting to the injury. It's not the original insult itself. And finally, Step 4. The growing end changes, highlighting growth disorders right there at the epiphysis or metaphysis.
Let's backtrack to Step 1 for a second. When a hole just opens up right in the middle of the bone shaft. This can be genuinely terrifying because these aggressive round cell lytic lesions often totally mimic each other. And that is exactly where you deploy the lemon mnemonic. Leukemia and lymphoma, eosinophilic granuloma and Ewing tumor, multiple myeloma, osteomyelitis, which, tricky enough, mimics a tumor, and neuroblastoma metastasis. When you spot an ill-defined, moth-eaten lesion right in the midshaft, retrieve this list. It organizes the absolute worst-case scenarios so you can confidently manage what's in front of you.
And finally, we hit Section 5, Pathology Triage, benign versus aggressive.
This is it. This is the ultimate clinical showdown, differentiating slow-growing benign variants from fast-moving aggressive pathology. Because in the real world, this is the triage that actually saves lives. Before you look at the matrix, before you even check for a periosteal reaction, look at the margin, the zone of transition. This is the absolute fastest read on any lytic lesion. A sharp, narrow margin where you could practically draw a definite line with a pencil, that strongly suggests a benign, slow-growing process. But a wide, fuzzy zone of transition where you can't really tell exactly where the lesion ends and normal bone begins, that just screams aggressive and fast-moving. It's the rule of contrast, and honestly, it's going to be your best friend.
And you know, the bone surface reaction? It literally tells you the tempo of the disease. A thick, wavy, uniformly dense periosteal reaction means the lesion is growing slowly enough that the construction crew can actually lay down solid new bone to contain it. But if you see a spiculated sunburst pattern, a laminated onion skin look, or a Codman triangle where the periosteum is basically lifted up like a tent, that means a malignant, aggressive process is completely outrunning the bone's defenses. The periosteum is being ripped up way before it can even consolidate.
Actually, let's jump back up to the skull for a quick second, just to apply this benign versus aggressive logic. Compare these two lesions. You've got a donut lesion, which is a lucency with a thick sclerotic rim. It's contained. It's safe. Usually it's just an incidental benign variant. But a button sequestration, a lucency with a central calcified nidus, that warrants a much closer look, especially if the patient is experiencing pain. It can absolutely be a variant, but it can also be a sign of infection, metastasis, or eosinophilic granuloma. You've got to know the difference between the safe donut and the highly suspicious button.
Listen, if you take absolutely nothing else away from today, let it be this. Measurement and tempo beat a Gestalt impression every single time. Don't just look at a film and guess based on a vibe. Actually measure the McGregor line. Measure the sella turcica. Look closely at the margins in the periosteal reaction to read the structural tempo of the bone. Systematically applying these architectural frameworks and precise measurements is always going to outperform rote memorization.
I want to leave you with this one final, honestly amazing thought. In children with leukemia, the disease creates these radiolucent metaphyseal bands right at the growing ends of the long bones. And when they undergo successful chemotherapy, those exact same bands turn dense and sclerotic. A single line on a film can literally chart the entire timeline of their treatment response. So I have to ask you, if a piece of bone can record history like that, what else is hiding in plain sight in the patterns you read every single day? Look a little closer at your next clinical film. The skeleton is always trying to tell you its story. Thanks for joining me on this explainer, and keep reading the patterns.